So welcome to the new year, to our first webinar of the 2025. We know that and you guys know all too well, that there are a lot of respiratory viruses going around, of about a whole bunch of different things that just seems to be infecting every family. So we wanted to have a sort of respiratory virus update for y'all. We haven't done one in quite a long time. So we're happy to have Dr. Del Valle here, who is a pediatric infectious disease doc at UAMS and Arkansas Children's, just to give us the rundown of everything that is going on. So Dr. Del Valle, I will hand it over to you to get us started.
Thank you so much for the invitation. As Katie mentioned, I'm one of the pediatric ID attendings at Arkansas Children's, but I also do, as part of my job, I'm the medical director of infection prevention and control. So, tracking respiratory virus is something that I do on a day-to-day basis. So happy to be talking about this here today. So as you guys all know, pediatric respiratory illnesses are extremely common, and it's one of the main reasons for pediatric hospitalizations, ED visits, outpatient visits, but not just that. It's one of the main causes of mortality in children in the US and worldwide. So we're going to talk a little bit about what's happening this season with respiratory viruses and other infections, because we're not only seeing respiratory viruses, we're also seeing some bacterial infections rise this season that we really didn't see last season. So this is a screenshot from one of our tracking tools that we use at Arkansas Children's, it is tracking the positivity rate for the 4 main viruses that we track each season, which is RSV, COVID, flu A, and flu B. So your numerator is going to be positive tests for that infection, and then your denominator is going to be all tests for that infection. So this is a screenshot of what we saw last season. So we had a little bit of everything last season. We started in July with a little bit of COVID, followed by quite long RSV season last year. We started around mid-August, September. Our positivity rate went up all the way up to 40% before we started seeing the numbers come down. And once we started seeing RSV leave the picture, flu came into the party, and we had both flu A and flu B, transmission from January to March. And then after March, we kind of saw things die down. So what are we seeing this season? So again, in the summer, we saw a little bit of COVID. We are not seeing COVID right now in significant numbers. We always are going to have, a positive test here or there, but nothing that has been super significant. We enter RSV season around, towards October, second week of October. We hopefully have peaked, towards the end of December, and we're coming down on RSV numbers. We're still seeing a high level of transmission. We're about like 21% for the past week, and we're coming down on RSV, but we're now seeing flu A trend upwards. We are not seeing a lot of flu B this season, if any. So this is kind of where we're at. But this season came with a few twists, right? We are seeing an increased incidence of both mycoplasma and pertussis. What's going on with avian flu? We'll talk a little bit about that. Should we be worrying about that or not? And, lately in the news, we've also been seeing increased reports of human pneumovirus, and we'll touch this briefly. I just wanted to touch on it because, we are seeing it in the news. Is this truly a problem right now or not? What are we seeing in our community? So as we know, RSV is something that we commonly see every season. and year-round. In temperate regions, RSV epidemics usually begin in the fall, they peak in the winter, and then by the spring, they're gone. So we expect that the majority of RSV infection/circulation is going to happen between October and March, and that is your common usual season. Right now, we are seeing circulation similar to that, with the start of the season starting in October, which is different from the 2023 season, where we saw the circulation started sooner in August. But it's also not unexpected to see some RSV infections outside of this period, right? Like, we are going to expect that RSV is going to circulate between October and March at the highest levels, but you'll see some RSV infections outside this period. So this is just an illustration to kind of show you guys that, as you know, RSV circulation is going to depend on where you live. So if you live in the South, you're not going to have the same RSV season that if you live in the Midwest, or if you live in the West or in the Northeast. And if you live in Florida, it's another completely different ballpark, because it's crazy over there and they have RSV all the time. So how do we track RSV season? So CDC defines that RSV season starts when you have 2 weeks in a row that you have 3% positivity rate or more for RSV. And it kind of depends. Our health department usually does 3%. Sometimes they do 5%. It kind of depends from, sometimes they use 3%, sometimes they use 5%. But for this purpose, we use 3%. So as you can see here, we probably started towards at the beginning of October, we went into RSV season. So that chart is for this current season that we're seeing now. We did experience some disruptions for RSV seasonality and other type of bacterial infections and other viruses during the COVID pandemic. So what we saw during COVID, was not typical, and it has taken us a couple seasons to try and kind of like go back to normal. What we're seeing during this season, at least from when we started, it is going back to RSV seasonality that we were having prior to the pandemic. So it could be that we're returning a little bit back to normal. As you saw from the initial chart, for 2023 to 2024 season, we started late August and we went all the way into April for RSV, which now we started on October, and right now we're in the middle of January, and we're already seeing some downtrend for RSV. We know that 1 to 3% of all children in the first 12 months of life will be hospitalized because of severe RSV. The highest rate of hospitalizations occur in the first 6 months of life, and some babies are going to be at increased risk for complications for RSV. So those are some of the reasons why we trend RSV so closely. We monitor the season, so we can sometimes, if we're able, to do some targeting interventions. Preventive measures within the hospital. We place these babies on contact and droplet precautions where they're hospitalized. Hand hygiene is still going to be your #1 level of defense for any type of infection, including viral infections like RSV. Good hygiene is going to prevent you from getting infected, as well as preventing transmission, horizontal transmission between patients. One exciting thing that we've seen with RSV in terms of prevention has been passive immunization. I'm not going to go into detail of like all the indications for palivizumab or nirsevimab or Beyfortus. That's like a whole different talk, and we could be talking for another 45 minutes about Beyfortus. So just kind of like in broad terms, we know that Beyfortus recommendations are based on if the birthing parent received the RSV vaccine during pregnancy, and the timeline of receiving this vaccine related to the birth. And palivizumab right now is being used more if Beyfortus is not available for those patients who are high risk of developing complications due to RSV either in their first or their second season. And we know, as you guys know, Beyfortus is indicated for those infants aged less than 8 months to protect against RSV associated complications in your first RSV season. And we've already seen, some numbers come out on what Beyfortus is doing with RSV and how effective it is to protecting infants from RSV-associated hospitalization and complications. There was an analysis that came out from the New Vaccine Surveillance Network that evaluated the effectiveness of nirsevimab, and they found that they look at around 700 infants, and they found that the effectiveness of nirsevimab was around 90% against RSV-associated hospitalization. And there's been some more data coming out of different countries, not only the US. There was a recent report out of France that across 6 hospitals, they found an effectiveness of 83% against RSV-associated hospitalization in those infants that received Beyfortus versus those with no intervention. This study preprinted in The Lancet out of Spain showed a reduction of 87.6% and 90.1% in hospital and ICU admissions for RSV, respectively, among those babies born before the start of the RSV season who were eligible to receive Beyfortus compared to those with no intervention. And there was another study out of Spain that was published in Vaccines that found an effectiveness of 88.7% in preventing hospitalizations among those infants that were immunized at birth with Beyfortus versus those that were not. So kind of like exciting things coming out with Beyfortus. Last season, we had a lot of, supply chain disruptions, and we had a lot of difficulty and with supply sometimes with getting nirsevimab for everybody. You guys probably know better than anyone what this season has been doing. I haven't heard a lot about having issues getting Beyfortus. But, sometimes it can be challenging, and we'll start getting and seeing more data as time goes by and more and more kids continue to get nirsevimab. So we'll talk a little bit about the flu. CDC estimates that on average 8% of the US population will develop symptomatic influenza during a typical season. And hospitalization rates are highest in those younger than 5 and older than 65. So similar to RSV, no 2 influenza seasons are exactly the same. It depends on year to year. During the 2023 to 2024 season, the severity of influenza season was classified as moderate. This is related to how many outpatient visits were seen with influenza, how many patients were hospitalized due to complications with influenza or due to influenza itself, as well as influenza-related deaths. And as you could see from the charts for last season, we did see both influenza A and B. This season so far, we're only seeing influenza A. B is really not been a player so far. And again, this season, we're seeing that the influenza levels and activities are coming back to what there used to be before COVID. COVID, again, it disrupted a lot of the way that viral illnesses and some bacterial illnesses were being transmitted in the community. So it seems that we're going back to what we're seeing before the pandemic, kind of going back to normal and seeing these viruses circulate. An important thing for influenza is that the vaccine changes years per year, and the vaccine effectiveness is going to change year per year as well. The influenza virus strains that are selected for inclusions in the season vaccine changed yearly, and they are selected based on the more predominant strains from the season prior to that, to the current season. So we don't have data for how effective the vaccine has been this season, but we do have data from this season prior. And the pooled vaccine effectiveness against influenza-related hospitalization for the 2023 to 2024 season seemed that it was the most effective in those between 6 months to 4 years of age, with that 72% effectiveness against hospitalization, and the least effective in those 65 and older, with about 35% effectiveness against hospitalization. And just some numbers to highlight, how influenza can impact our healthcare system and our different populations, right? So during the 2023 to 2024 season, the CDC estimated that influenza vaccination prevented 9.8 million influenza-related illnesses, 4.8 million medical visits, 120,000 influenza-related hospitalization, and 7,900 related deaths. So just highlighting the importance of vaccinating season with season, year per year for those for your patients to try and prevent influenza-related complications. So what about avian flu? We've been seeing a lot in the news about potentially increased cases of avian flu in the US. Could this be the next pandemic? What are we seeing? Well, the answer is we don't know if this could potentially be the next pandemic, but it is definitely something that we're keeping our eye on. Avian flu is not exclusive to the US. It is present in wild birds worldwide. It was first identified in southern China in 1996. It is caused by a subtype of influenza A. So it's influenza A subtype H5N1. And this is mainly known to cause outbreaks in poultry and dairy cows. And that's what the main thing that we're seeing in the US, besides seeing some human cases, we're seeing more and more cases of dairy cows being infected, and both poultry and wild birds as well. And the majority of the cases that we've seen in humans are related to US dairy and poultry workers, so people who either handle birds or work with cows. The CDC reports, puts out the MMWR, and they report what they're seeing with avian flu kind of frequently. And there are some human cases where they haven't been able to kind of track back where they got it or didn't find the exposure, but they haven't found any evidence that there has been human-to-human transmission of H5N1. Right now, it's thought that it's potentially not possible for it to be transmitted human-to-human. But as I think the danger of what we talk about as we continue having cases is the potential for the virus to mutate to the point where it would be possible for it to have some sort of human-to-human transmission. The main, human infection with bird flu or influenza H5N1 can happen when the virus enters up through a person's eyes, the nose, or is inhaled. As we talked about, those with close contact or prolonged contact with infected birds, cows, or the contaminated environment without proper protection are an increased risk for infection. And the clinical symptoms range from mild symptoms such as a URI, conjunctivitis, to severe illness. One thing that makes all these respiratory viruses so challenging is, well, they all kind of look like alike, right? It's hard to see someone and say like, oh, you have the flu versus you have, this other virus or human metapneumovirus. One thing that has been reported with influenza H5N1 that seems to be very predominant is the conjunctivitis. It seems to present with very severe conjunctivitis, looking almost hemorrhagic. So I think that's one thing that can kind of ring the alarm when you're seeing a patient, is if the severity of the conjunctivitis, particularly if they have that exposure of, hey, I work in a dairy cow farm, or I have 3,000 birds in my backyard, or I have some sort of other animals around. So what is the situation right now? In 2024, there were 67 total confirmed human cases in the US, which is kind of like the most amount of human cases we've had. And we did have one death associated with H5N1 out of Louisiana. This was a 65-year-old that developed severe disease. He did have some comorbidities as well. But it is, the first death associated with H5N1 in the US. We have not had any clinical cases in Arkansas, but one thing, that to keep in mind is that we have seen it in birds. So we have seen the health department, both the health department and the agricultural department report the cases, the number of cases identifying poultry. And there has been so I have the number here. And we've had seen avian influenza both in commercial poultry plants as well as in some quote unquote backyard flocks. So we've seen it primarily in birds here, but no, we have not seen any human cases. The health department does work really closely with the our agricultural department in terms of tracking these cases. In terms of what we are doing, the CDC does recommend that clinicians should consider the possibility of H5N1 infection in patients showing signs or symptoms of acute respiratory illness. And as I said, one of the main symptoms that they have described is the conjunctivitis in those patients that had relevant exposure. And they described, the relevant exposure history at those that are in contact with potentially infected or dead birds, livestock, or other animals within 10 days of symptom onset. Direct contact with water or surfaces contaminated with feces, unpasteurized milk, or unpasteurized dairy products, or parts of potentially infected animals. So we can test for avian flu. Those tests go directly to the health department, and I don't know if I believe they send it to CDC or they do it there. But if you suspect a patient that may have avian influenza, contact the state public health department to arrange testing. You can send nasopharyngeal swabs, but also you can send conjunctival swabs as well for testing for H5N1. We have done it. We have, way back a couple months ago, we had a patient that we were suspicious for H5N1 just based on exposure history, and we arranged for testing with the health department, and they're always hope to help, and it's a pretty easy process. Another thing that we do is when we do our PCR tests at ACH, you do an RPP, and then the influenza A comes back as untypable. All of those tests get sent to the health department to make sure that they get subtyped to try and find out what type of influenza it is. So we send all of those samples to the health department, and they get tested. We have had several untypables, identified in the lab. We have not seen any H5N1. So what about COVID? Anything new with COVID this season? Again, I think now we're all aware that COVID is here to stay. It's not going anywhere. We're going to continue to see some ups and downs in transmission, just like any other virus. It remains an important cause of morbidity and mortality. We will have the higher risk of complications among those 65 or older and those who are immunocompromised. And it circulates year-round, with infections and hospitalization peaking in late summer and winter. So as you can see, we did have a peak in July. We have not seen a peak in the winter so far. We'll see what happens. But we have definitely been seeing a little bit less COVID than last year. The Advisory Committee on Immunization Practices does recommend it for the 24 to 25 COVID-19 season to give vaccination for everyone older than 6 months. And for those older than 65 or at increased risk of complications, to receive a second dose 6 months after. The mRNA vaccines for 2024 and 2025 target SARS-CoV-2 strain called KP2, which was the most predominant circulating strain. But again, COVID, we have not been seeing a lot of it this season. So it is actually not been a main player this season so far. So what about, our other kind of unwelcome guests this year? We've seen a lot of mycoplasma this season, and it's been interesting to see how it's affected kind of like an uncommon population that we had not seen before as being the most common population affected by mycoplasma. We do know kind of like what everybody teaches us both in like med school and during PEDS residency, that it's more of a school-age children, young adult infection, but this season we've seen it affect more and more younger kiddos, including kiddos younger than 2. And again, kind of difficult to diagnose clinically sometimes, particularly when it is presented outside that classic age range, because it can look like any other infection, right? So you can have some fever, some coughs, or some throat, and that can be anything. We also see some unusual manifestations with mycoplasma, such as CNS disease, myocarditis, arthritis, MRM, HLH. This season alone, I've seen 2 or 3 cases of autoimmune encephalitis due to mycoplasma. I haven't seen any myocarditis yet, but I did see some MRMs. So we've seen a lot of mycoplasma this season, and a lot of more of these autoimmune associated complications that we see with mycoplasma post-infection. So the incidence of mycoplasma varies season to season over time. We do tend to see some cyclical outbreaks in terms of or increased transmission of mycoplasma every so few years, kind of similar to what we see with pertussis, and we'll talk about pertussis a little bit more. But it is not unusual to see, a peak of mycoplasma, and we have a really bad season, and then, a couple of years go by and we don't see a lot. We see a case here and there, and then a few years later, we see again, oh, well, we're seeing a lot of mycoplasma. One thing that is, atypical of this season compared to, other seasons is not only the fact that it has affected younger children, but also that we did have a very prolonged period of time without a lot of mycoplasma circulating. Again, most likely related to the COVID pandemic. And now we're kind of bouncing back to seeing a lot of mycoplasma. Oh, let me see here the chat. Is mycoplasma still very active in the community? Actually, now we are seeing a little bit of a downtrend in mycoplasma. So this is from the surveillance system in the CDC, and you can see, that we saw a peak of mycoplasma all through like August, September, November, December, and now we're kind of trending down. And this is very similar to what our internal numbers are showing. We are still seeing some, but definitely not at the levels that we were seeing in the earlier months. I think, we're on the way down for sure. We're not seeing as much. Another interesting thing, about mycoplasma. We all know that macrolides, azithromycin, as the first-line antibiotic treatment for mycoplasma. But resistance to mycoplasma, resistance of mycoplasma to macrolides has emerged in the early 2000s, and it has been increasing since. So the CDC does do surveillance in terms of trending resistant patterns of mycoplasma throughout the country year per year. Overall, it is estimated that the prevalence of macrolide resistance to mycoplasma may be around 28%. But there is very significant geographical variation in terms of how much resistance you see. So the resistance that we see in the US is not the same as the resistance that they see in Asia or in Europe. We tend to see a little bit less resistance than other countries, about like less than 10%. But it does seem that, it varies from like geographical region in the US as well, with the south and east of the US seeing a little bit more resistance to mycoplasma than other parts of the United States. For example, in China, macrolides are not the first line of of treatment because they have a very significant amount of resistance to microlides for azithromycin, about like for mycoplasma for about 80%. So I'm sure that you guys probably saw the AAP came out with a communication that regarding not only the increased rates of mycoplasma pneumonia in the community, but also the fact that we should consider using second-line agents when you have a patient with mycoplasma that is not improving in azithromycin, to consider switching them to either doxycycline or fluoroquinolone. So we definitely saw a lot more mycoplasma this season. We definitely saw a lot of more severe mycoplasma this season than other seasons. And we did have, at least me personally, several patients that I had to use a second-line agent because they were not improving on azithromycin. So another twist to the season has been pertussis. We have seen an increased number of pertussis, not only in Arkansas, but throughout the US. We do know that, why do we care about pertussis? Why do we track pertussis? Well, because our population is at increased risk of having severe complications due to pertussis. So neonates are in increased risk for hospitalization and complications. And infants younger than 1 year of age are that's a group that is at an increased risk of complications, as well as those who are immunocompromised. Infants younger than 1 is kind of like the ones who are at increased risk, and particularly the newborn neonate population, premature babies are in increased risk for having severe complications for pertussis and even death. So we know that pertussis not only has a very prolonged incubation period, so it can incubate for up to 21 days, it also has a very prolonged illness period. And it has these 3 different stages: the catarrhal stage, the paroxysmal stage, and the convalescent stage. And the duration of all 3 stages can be between 6 to 10 weeks. And the cough can last forever. And because it has the 3 different stages, sometimes it can go unnoticed, right? Because the catarrhal stage looks like a simple cold, and then you might think that the paroxysmal stage may be some post-ossive, some cough lingering from that initial URI symptoms. So sometimes it can be very difficult to diagnose. We do have PCR tests that are commercially available. And we also have some serology tests that we can use that are not usually what we do first line, but they are available for diagnosing pertussis. Transmission can occurs via droplets. Cases occur year round, but typically they have a late summer autumn peak. We definitely saw a higher amount of cases in October, November, with December having trending down, and now in January we have not seen as many cases as we were seeing in the previous months. One of the most challenging things about pertussis is that neither infection nor immunization is going to give you lifelong immunity. So the vaccine for pertussis is, it gives you immunity, but it's not lifelong immunity, and it's not a great vaccine in terms of how long it protects you for. So if you're not keeping up with your boosters, you're gonna still be susceptible to getting pertussis. So I think, waning immunity has always been the predominant cause for having increased cases for pertussis, and we're also seeing, more vaccine hesitancy, less people getting vaccinated. If moms are not getting vaccinated, then those newborns are at increased risk of developing pertussis, and then they're in the community where the adults are also not vaccinated. So, I think it's been multifactorial as to why we're seeing a lot of pertussis this year. So kind of like that immunization side, plus we didn't see a lot of pertussis during the pandemic as well. We've had a huge gap of probably like 4 or 5 years where we didn't see a lot of pertussis. And now we're kind of bouncing back and seeing, and kind of going back to a normal where we see some sporadic cases of pertussis, but with right now it has been a few months of a lot of transmission, a lot of cases in the community. Pertussis is highly contagious. As many as 80% of the susceptible household contacts of symptomatic infant cases are going to end up getting infected with pertussis. So it's something that is very contagious. And that plus, we don't have a great vaccine, kind of sets up the perfect storm for ongoing transmission in the community. The infected people are most contagious during the catarrhal stage, but they're also contagious all throughout the 3rd week after the onset of paroxysms. So you're going to be contagious for about 21 days, unless you receive treatment. So if you receive, azithromycin, Bactrim, whatever you're using to treat pertussis, azithromycin being the first line therapy, you should isolate for 5 days until you complete your antibiotics. So just some data from the CDC in terms of where we are for 2024. We have had 6 deaths related to pertussis, and those less than 1, and 4 deaths for those more than 1. So it seems that we're probably, again, returning to the pre-pandemic patterns of transmission of pertussis. But we have had more than 6 times as many cases reported at the end of 2024 compared to the same time in 2023. So a lot of more transmission of pertussis than what we were expecting for this year. Again, I think based on what I'm seeing from our internal numbers, we're seeing less amount of pertussis. Our tests, numbers for pertussis does not reflect community transmission as well, because it is not where as COVID or flu or RSV, when you can test them really easily and you can kind of follow those numbers more closely. We're probably under testing for pertussis is probably going more unrecognized than other illnesses. So probably what we're seeing, there's only reflects a little amount of probably how many cases we're seeing of pertussis in the community. So it is an nationally notifiable disease. We do report all of our positive tests of pertussis to the health department. It is done automatically. We have a kind of like a data sharing agreement with the health department, so all of that gets transmitted over to them, and notified, because they have to do contact tracing to make sure that everybody that needed to get prophylaxis got prophylaxis. A lot of these outbreaks happen in schools, so they have to send those letters that you guys are probably familiar with, and then the kiddos showed up to the clinic with the letter showing like, hey, you have been exposed to pertussis. As I mentioned, the diagnosis can be made via PCR testing or serology. We rarely use serology. This is more kind of like late in the illness. If you're worried that you have potentially already a negative PCR test, although about 50% of the PCR testing for pertussis will stay positive beyond 21 days. So it kind of depends. The treatment consists of 5 days of azithromycin. Post-exposure prophylaxis, it is recommended for all household contacts of the index case and other close contacts, including children in childcare, regardless of immunization status. Again, this is because the vaccine is not that great. So then just prophylax everyone. It doesn't really matter if they're vaccinated or not. And those who are non-household contacts with, you don't really know how much exposure they had to pertussis, then you should administer prophylaxis if the individual is at high risk or will have close contact with a person at high risk for severe pertussis. Close contacts who are unimmunized or under-immunized should have immunization initiated or completed. So again, we're seeing less pertussis. I think in terms of mycoplasma and pertussis, I'm hopeful that we're in our way out and we're seeing less and less transmission. And what about human metapneumovirus? A couple of weeks ago, it was kind of all over in the news, like, oh my God, we have another pandemic coming out of China, and what is this virus that nobody knows about? I mean, you guys know it's been around for years. It is nothing that is new. Transmission occurs by direct or close contact with large aerosols or droplets, as well as fomites. And in temperate climates, human metapneumovirus usually occurs during the late winter and early spring. So we are not seeing any human metapneumovirus yet. I mean, maybe like 1 or 2 here and there, but nothing that is, a concerning trend. And I think since the pandemic, a lot of things still, everybody's very hyper vigilant and things can kind of get blown out of proportion. China has reported that their level of respiratory infections are within normal range. They did have an increased incidence of human metapneumovirus, but the proportion of how many viral infections they see per year is kind of like within what they expected. So in terms of how it does affecting us, I don't think, at least for now, we're not seeing anything that is unusual for human metapneumovirus. But as we can track all other viruses with that tool that you guys see at the beginning, we can track all other viruses that are in the RPP. So we do kind of keep an eye on what viruses are circulating in the community besides those main 4 that we kind of talked about today. One thing for you guys to know, that tool that you guys saw, that's our internal tool with EPIC. We do send an ACH kind of like a weekly report to our faculty, our fellows, our residents, and some of our nursing leadership as well. But this year, something that we have collaborated with the health department is we do have now a data sharing agreement, and we send them all for positive tests. So now what the health department reports in a weekly basis, they kind of release a weekly report of what the viral activity is, and they have included pertussis this season as well. So you can kind of track our numbers here, because these are the same numbers that we are seeing in our internal data in terms of our positivity rate and what the viral season is doing. Main difference is that they divide the flu A by subtypes when we just group them all together. But you can see kind of like the same things that we were seeing right in my initial charts, right? How RSV kind of have came up. Again, flu looks a little bit different here because they divided by subtypes. What we're seeing this season is primarily H1N1 and H1. And then I just put this here. So this is where you can find that weekly viral respiratory disease report in the Arkansas Department of Health website. You can either Google Arkansas Department of Health weekly viral respiratory disease report, and it will send you to this, or you can go to the Arkansas Department of Health website and look for the influenza reports, and then that's where it's going to be under this information, and they update it week per week. And there's some other stuff that they put in there for like more widespread, like state information and not only PITS data. But if you want to see the PITS data that we are seeing, you can see it there. And that's kind of like all I have for today. I just wanted to give you guys a broad overview and a big picture of what we're seeing this season in terms of viral illnesses and bacterial infections. And again, I'm hopeful that things are getting better and that pertussis and mycoplasma are going to leave us alone for a little bit, and that RSV is on the way down. We'll see what flu does this season. But overall, I think, the trends are looking a little bit better.